Good evening, good afternoon or good morning, everyone, wherever you are. Welcome to this webinar in the series Gender Responsive Budgeting and Progressing Breastfeeding Policy. Our program of webinars since 2020 has aimed to galvanise efforts to improve breastfeeding policies and investments by applying a gender lens to government budgeting on breastfeeding. Our topic tonight is Tooling Up the Baby-Friendly Hospital Initiative, Maternity Care for Gender Justice and Human and Planetary Health. I'm Associate Professor Julie Smith from the Australian National University and the University of Canberra. My co-chair tonight is Dr. Andini Pramono, also from ANU. This event is jointly organised by the Tax and Transfer Institute at the ANU Crawford School of Public Policy and the Health Research Institute at the University of Canberra. We acknowledge and appreciate research funding from the Medical Research Future Fund, Alive and Thrive East Asia Pacific, and the ANU Gender Institute. We also appreciate the support of FHI 360, the Healthy Environments and Lives Global Research Centre, the World Breastfeeding Trends Initiative Australia, and the Breastfeeding Promotion Network of India. Tonight, we look at maternity care policies or practices that affect human or planetary health and social equity in what they do or don't do for successful breastfeeding. I'd like to acknowledge that this meeting is being hosted on the traditional lands of the Ngunnawal people. When first encountered by European settlers in the 1820s, Ngunnawal people lived around the Yass area near Canberra, now Australia's national capital. On nearby country were the Namadgi, the Wiradjuri, and the Gundungurra peoples. The Indigenous women of Australia have been living, working, birthing, breastfeeding and raising children successfully on this country for tens of thousands of years. Their skills and knowledge about safe infant and young child feeding, including breastfeeding and safe complementary feeding, has been key to their health and survival. We've much to learn from Indigenous women and from their history. I would like us to acknowledge and celebrate the first Australians on whose traditional lands we meet and pay our respects to their elders, past, present and emerging. As well as my co-chair, Dr. Pramono, and our co-presenters, Diane Paul's been working hard behind the scenes to ensure the webinar series runs as smoothly and productive as possible. Remember, we're recording the event so you can view it later if you need to step out, but please put your audio on mute. All questions and comments will be taken via the chat function in Zoom, and we'll bring this together at the end of the evening. If there's any unpleasant or bad behaviour in the chat, you're out of here. Our expert speakers will now take us through the program. Firstly, David Clark will deliver some opening remarks. We'll then have presentations from me, Ms. Constance Ching, Ms. John Nak-Pitaks, Dr. Andini Pramono, Professor Nasa Bagheri and Dr. Duan Nguyen. Armed with new knowledge about scaling up BFHI, code monitoring health facilities, mitigation actions in healthcare, gender-just investments in maternity care, and equity of access to BFHI standards, we'll learn about measuring the environmental impacts of infant formula products using the green feeding tool. Several presenters from different countries will then outline their experience in using the green feeding tool, and we'll see some results from its recently enhanced functionalities. Professor Jenny Gamble will then bring it all together for us, offering her thoughts on gender justice impacts of scaling up BFHI in maternity services. And then Roger Matheson will conclude the program with a brief reflection and celebration of our research collaboration. Please read the brief biographies for this wonderful lineup of presenters. The biographies are online in the program document. So now I would like to introduce David Clark, who will deliver the opening remarks from the United States by video. David Clark is an international public health and human rights lawyer and was the legal advisor for the UNICEF Nutrition Program from 1995 to 2020. David was instrumental in assisting more than 60 countries in drafting legislation to implement the International Code of Marketing of Breast Milk Substitutes and subsequent resolutions of the World Health Assembly, the Code, and in working with the Baby-Friendly Hospital Initiative to implement the Code into healthcare systems across the globe. Please welcome David Clark.
Hello, it's a pleasure to be with you, albeit virtually, for this important webinar looking at not only how the Baby Friendly Hospital Initiative protects, promotes, and supports breastfeeding, but also the effect it can have on reducing environmental impact. Um, Given my experience and involvement in the past with BFHI, I wanted to focus on the protective aspects of the initiative and particularly how it helps us implement or ensure that the International Code of Marketing of Breast Milk Substitute is uh, implemented in healthcare facilities. So I want to start with a basic kind of fact that I think we should all be aware of, and that is recognizing and dealing with conflict of interest in infant and young child feeding. No matter how helpful the baby food industry says it wants to be to us, uh, they want to help us in promoting breastfeeding, for example, we have to realize that we have completely conflicting interests. As health professionals or public health advocates, our primary interest is improving health and nutrition outcomes, and we know through the research that the way to do that is to increase breastfeeding, while the baby food industry, on the other hand, their primary interest is to increase the profits for their shareholders. In order to do that, they have to sell more of their products. And in order to do that, they have to reduce and undermine breastfeeding. So we have to bear that in mind at all times. Now, the commercial benefit of medical endorsement has been sought and used for decades. I mean, the professional endorsement, medical endorsement, is a very successful conduit for promotion of products, even unhealthy products. In the past, this is from the last century, we can see that tobacco companies were using the health professional to get endorsement to promote their products. The same was of the soft drink companies uh, getting these sort of adverts to sort of show that these are health drinks or whatever, but very successfully. Um, the public puts a lot of faith in what is considered healthy or what the medical profession might endorse. And of course, we had the same thing for breast milk substitutes before the code, including recommending here to use carnation milk for the feeding of babies, not a recommended practice, I'm sure you all know. And today, the endorsement, the medical endorsement is more subtle, but still there and still effective. This is an example from Russia where this company has clearly paid the Russian Pediatric Association to carry its logo, saying that these formulas are recommended by the Russian Pediatric Association. Again, something that parents would put their faith in and therefore increasing sales of this product. In some places, again, the companies that want to help us, they will provide the white coats for the pediatricians, of course, with the company name and logo, um, or growth charts, another thing that we will find in hospitals that don't comply with the code. Uh, and I've been talking about this code just so that we're all on the same page. I'm talking about the International Code of Marketing of Breast Milk Substitutes, adopted in 1981. It's a recommendation to all governments to adopt national regulations, and these should be legally enforceable regulations, updated regularly by the World Health Assembly through its resolutions so that it's kept up to date and deals with new marketing tactics or products. It protects women. In fact, it should protect everyone from misinformation by prohibiting all advertising or other forms of promotion of breast milk substitutes, feeding bottles, and teats. Prohibits the use of healthcare system to promote breast milk substitutes and protect health workers from the influence and pressures from the baby food industry. and it requires governments to provide parents with and caregivers with objective and consistent information. Just very quickly, the slide from a very reputable source, I might add, shows that in countries where they have good code implementation and enforcement, the trends in formula milk sales are stagnant compared with those in countries that do not have good code regulations in place, showing us that the code does work in protecting breastfeeding. How does the code help when we're talking about healthcare facilities? Well, it says that healthcare facilities are not to be used for the promotion of products within the scope of the code, and there should be no display of products within the scope of the code or distribution of material provided by a manufacturer or distributor. But in fact, the code had a lot of loopholes. The code, as it was adopted in 1981, it allowed companies to donate equipment and materials which can bear the company's name or logo. It only prohibited financial or material inducement to promote products within the scope of the code. So a lot of companies would give pens or calendars or other things which they said were not financial or material inducements, but they had a very promotional effect being seen in doctors' offices or whatever. And it allowed the companies to make contributions for fellowships, study tours, etc., as long as those were disclosed. So again, another very big loophole. And you know, the social science research shows that the impulse to reciprocate for even the smallest gifts is a powerful influence on people's behavior. And people who are receiving gifts, they may think that they remain objective, but they're often unable to remain so. And they reweigh information and choices in the light of the gift. And no strings attached still carries an expectation of some kind of reciprocity. Remember, those companies are only trying to, are spending the money to make these gifts or provide that support because they are aiming to undermine breastfeeding in one way or the other. We now, since 2016, we had one of these important resolutions I was talking about, which has a guidance on ending the inappropriate promotion of foods for infants and young children. And it really provides us with some very good recommendations on what is no longer allowed in terms of conflict of interest within the healthcare system. So no more of these gifts, no more providing equipment, whether or not they have the name or logo of the company, no sponsorship of meetings for health professionals, etc. This puts us in a much stronger position. I just wanted to remind us that when the Baby Friendly Hospital, it was one of the operational targets in the 1990 Inocenti Declaration. You can see there it was placed separately from the code. So we've got the 10 steps to successful breastfeeding, which was one of the which was the basis for the Baby Friendly Hospital initiative, and the code as separate targets. I guess everybody assumed that by 1995 every country would have adopted the code and therefore it would be applied in the healthcare facilities, but we know that didn't happen. So in fact, the 10 steps to successful breastfeeding, as they originally appeared, don't mention the code at all. And so you could actually have countries or hospitals where there were code violations, but they could still be baby friendly. So that was resolved a little bit to a certain extent in 2009 when the BFHI documents were revised, and they included a new section on compliance with the code. And here, this is just a screenshot. You can see there was global criteria for code compliance, and it went through a lot of the things I've been talking about, the things that that would put a stop to conflict of interest in those hospitals. Again, we had a further look at the BFHI in 2017, much more user-friendly poster for the 10 steps now. And this was really to look at the evidence to make sure that BFHI and the 10 steps could be presented as evidence-based. So, in conclusion, I just wanted to leave you with the following thoughts. Um, Firstly, we need to remember that the baby food industry and we, the public health advocates and professionals, have completely conflicting interests. And therefore, the involvement of the baby food industry in baby-friendly hospitals or any health facilities represents a serious conflict of interest and undermines breastfeeding, thus undermining the rights of mothers and babies. I also want to remind you that implementation of the code, when done properly, it protects the general public and the healthcare system from the misinformation and manipulation of the baby food industry. And finally, that BFHI should be seen as a means to ensure implementation of the code in hospitals, keeping the baby food industry at arm's length and protecting mothers, babies, and health professionals from their aggressive and unethical marketing ploys. And with that, I'd like to thank you for your attention, and it gives me great pleasure to open this webinar with these remarks. I wish you all the best over the next couple of hours for, as you discuss these important matters. Thank you very much.
Well, a virtual thank you to the wonderful David Clark. So next on the program is in fact me, and I will be talking about scaling up BFHI in Australia, integrating the 10 steps into policy documents and professional standards of care. In 2015, the WHO and UNICEF initiated a comprehensive review to strengthen and revitalise the baby-friendly hospital initiative. As part of this effort, WHO conducted a thorough evaluation, as David mentioned, of the evidence supporting each of the 10 steps, and UNICEF did some key country case studies. Case study themes that emerged included resourcing and government commitment, health worker capabilities, and the role of champions and social mobilisation. Following this, again, as David mentioned, an updated implementation guide was issued in 2018 to assist countries in effectively adopting the BFHI. This guidance emphasises scalable strategies for achieving universal coverage and long-term sustainability. It highlights the importance of integrating the initiative into the broader healthcare system to ensure that all facilities adhere to the 10 steps and to ensure that the 10-step standard of care are equitably available to women. The formula industry works to a marketing playbook that includes marketing and health services. The 2023 Lancet series exposes how the CMF industry marketing strategies exploit parental vulnerabilities and capitalise on policy and program gaps, including in BFHI implementation. Commercial milk formula products, including specialised formulas, are marketed to parents and health professionals as solutions to pathologised infant behaviours, such as crying, fussing, or sleeplessness. Health professionals, often poorly equipped to assist mothers in managing these concerns, unknowingly become central to formula marketing. The industry frequently provides their continuing medical education on infant feeding because governments and education institutions fail to provide adequately for this. Shockingly, the Lancet study number 2, documented that formula companies view health professionals as key category entry points for marketing CMF products. Gendered messaging and the illusion of choice is also part of this ecosystem. Marketing tactics in the industry playbook leverage gender stereotypes, framing formula as liberation in a can. And the industry narrative redirects attention towards individual choice, while conveniently obscuring the structural barriers and policy deficiencies that constrain women's infant feeding decisions and thwart their intentions. Furthermore, the Lancet Series Paper 3 reveals how the global formula market boom in low and middle income countries in the past decade gave a accumulation of immense financial power to these corporations to shape the infant feeding ecosystem. Formula companies can exert significant influence over regulations and public health policies, often in their own commercial interest rather than public health. So most people here, I think, will be familiar with the PROBIT study, which was a large cluster randomised controlled trial that evaluated the BFHI 10 steps. And I'll remind you, it demonstrated a 22 percentage point reduction in formula use at 4 to 6 month age group for babies in the intervention hospitals. Further research since that time, including studies led by Marie Tarrant in Hong Kong, has replicated the significant impact of specific BFHI policies on breastfeeding rates in Hong Kong hospitals. For example, requiring hospitals to pay full price for formula increased the likelihood that postnatal women experienced the BFHI 10 steps in their hospital care. Restricting a hospital's receipt of free or low-cost formula led to an approximately 20 percentage point increase in exclusive breastfeeding rates in this pre-post study. In this recent large study of 4 public hospitals in Hong Kong, led by Jeffrey Shring, we can also see the influence of comprehensive implementation of BFHI policies and practices on infant formula use. In this study, the risk of early cessation of exclusive breastfeeding during the first 26 weeks was consistently about 20 percentage points lower in the population that experienced the BFHI 10 steps. And the area between the curves in Figure 4 represents the reduced use of infant formula due to BFHI maternity care practices. Think about it, that's a lot of CMF infant formula sales lost. Australian governments have indicated policy objectives of protecting, supporting and promoting breastfeeding by encouraging hospitals to become BFHI accredited, by ending inappropriate marketing of infant formula and breast milk substitutes, and by increasing health professionals' education and training that is free from commercial influence. The Australian National Breastfeeding Strategy of 2019 and beyond was clear in what all Australian jurisdictions committed to do and who did what. But no budget was allocated, and it's not integrated into the wider hospital accreditation system. 5 years later, little has changed. So what's going on? We've got good evidence replicated in different countries with good fidelity of the intervention, and yet we see minimal progress in scaling up BFHI in Australia. So our research project is funded by the Medical Research Futures Fund. And in a nutshell, we hope to improve understanding of what drives BFHI uptake and scale up, to find out what birthing women want and what would help promote the 10th step. And in terms of the bigger picture, what gets in the way of scaling up BFHI 10 steps at a health system and societal level? Is it negative feedback loops? Is it real-world factors that dilute its appeal to key stakeholders, policy and health decision makers? The problem we have is the recent study led by Charlotte Media indicates that 1/3 of babies in New South Wales and Victoria, which is more than half of the Australian population, are fed formula in hospital. Moreover, in New South Wales, this data set shows a steady rise in formula use that increased from 20% in 2010 to over 30% by 2021. Notably, though, in Tasmania, available data shows that formula use has declined slightly over time, reaching around 13% in 2020, despite the state's high levels of social disadvantage. Very relevantly, all 4 Tasmanian hospitals are BFHI accredited. I'll now provide a quick overview of our Scaling Up BFHI in Australia research project and focusing on these 4 BFHI practices and policies that firstly illustrate the less visible obstacles to scaling up, and secondly that identify the gender budgeting aspects of moving to a more environmentally sustainable maternity care system. The aims of the research are to examine the equity of access and social fragmentation in relation to breastfeeding and health outcomes, to assess the preferences and economic value that maternity services consumers place on the implementation of BFHI, as well as to develop information resources and evaluate their effectiveness in engaging consumers on the BFHI Step 10. Earlier, I pointed to some of the evidence demonstrating that implementing the BFHI 10 steps, whether individually or in combination, is an effective intervention. And I asked the question, why isn't it widely implemented? And the answer partly lies in its complexity. Implementation science underscores that successful scaling of even a proven effective intervention must consider other factors: fidelity and replication, ensuring that the key elements remain consistent when implemented across different settings. Target population is not just individual mothers, but who else needs to be involved? Healthcare professionals, managers and policymakers who play a crucial role in adoption and maintaining the intervention. And also the context of implementation, including sources of resistance to BFHI. The 2016 Lancet series highlighted the broader structural and health system determinants of breastfeeding. But as I mentioned earlier, the 2023 Lancet Breastfeeding series documented the political economy of infant feeding, revealing also the gendered healthcare and financing systems that shape investments in maternity care. The power of corporations in influencing policies, not merely through direct marketing within healthcare facilities, but through systemic influence, adds another layer of complexity. This reality positions the CMF industry as an invisible yet influential stakeholder in BFHI scale-up efforts. A gender budgeting lens can offer valuable insights in how gender-biased financing systems can create obstacles to implementing, for example, Step 2, health professional education and training in health systems. As is evident, BFHI is not a simple intervention, but rather it's complicated and complex and requires careful navigation. So to help our understanding, our MRFF study will apply what's known as the non-adoption, abandonment, scale-up, spread and sustainability framework that's been developed by Trish Grenhall. This framework provides a structured approach to organising and analysing complexity in the scaling up of BFHI. And in the diagram on the right, you can see there, for example, that this first element of our study sits within that wider system in Domain 6, and the other two study elements relate to the adopter system in Domain 4. So in Study 1, we'll hear more about this shortly, but we'll look at who gets access to the BFHI 10 steps and what lies behind that. Who provides the resources needed to underpin the change? Who are the champions for it, and where do they come from? What does this mean for who benefits and who loses from BFHI? So this work will generate a visual map of Australia's hotspots for exclusive and continued breastfeeding and access to the BFHI accredited hospitals, and the role of social cohesion or fragmentation. And what we'll hear about tonight, actually, is a preliminary geomapping study using publicly available New South Wales state data that we conducted and disseminated through national media coverage when the project launched this time last year. The second element of our research is more technical. It's an economic analysis of survey data that will help to understand demand for BFHI 10 steps. This is a technique that's evolved from marketing research, actually. So we'll be asking, what do women value about it, and which of the 10 steps are the most important to their choice of hospital, as well as distance from their home and factors like that. And in the imaginary world of economics, how much would women be willing to pay for maternity care standards that ensure they meet their breastfeeding aspirations? So this activity will deliver a willingness to pay study, as it's called, to identify the attributes that drive preferences of childbearing age women when deciding on a hospital and their priorities for breastfeeding support. And the third element of the study will bring together the findings of the previous two elements. We'll work together with our partner organisations to develop effective information resources on the 10th step to link new mothers with breastfeeding support outside the hospital. And this co-design work will generate new knowledge on how to enhance the appeal of the 10th step for mothers in giving birth in hospitals, as well as for breastfeeding, health professional breastfeeding advocates. So I'm pleased to announce that the Baby Friendly Project webpage and information on these 3 study elements is now live at the University of Canberra, where the project is now hosted. So there's a place for you to go to keep in touch with what we're up to. Finally, I wanted to refer to 2 important but the less visible obstacles to BFHI scaling up that I touched on previously. Industry pricing of infant formula in Australian health facilities, BFHI Step 1. My investigations suggest that infant formula is supplied to Australian health facilities at widely varying prices compared to retail levels. Notably, one of the 2 major players aggressively prices its products at half the current retail price of the same product. Moreover, some of these low-cost supplies may not be paid for at all. According to insiders, invoices for payment are issued but not actively pursued by the company if they're not paid. We need a thorough and comprehensive audit of facility practices in this regard. And secondly, regarding BFHI Step 2, industry influence on health professional education. Health professionals are currently receiving free educational sessions in Australia on mixed feeding, provided by one of the 2 largest formula companies. Additionally, some health professionals act in alignment with industry interests and outside the relevant NH&MRC guidelines for health professionals in supporting those webinars. The lack of transparency surrounding financial support from the CMF industry is deeply concerning and raises ethical concerns about potential conflicts of interest in professional guidance on infant feeding, as well as concern at the lack of gender equity in government budgeting for health professionals' training and education in maternity care. The industry's hidden subsidy to maternity services presents a significant structural barrier to scaling up BFHI in Australia. It could be worth millions of dollars a year to Australian hospitals. A crucial step in implementing the BFHI is therefore a Commonwealth state funding agreement to ensure state governments and facilities transition away from this reliance on cheap formula supplies from the industry, and also can eliminate the formula industry influence in the education of health professionals. So we're about to explore now how the Baby Friendly Hospital Initiative can drive a gender equitable transition towards better health and more sustainable maternity care services. Before we finish, I couldn't resist offering some numbers. Infant formula sold in Australia contributes around 67,000 metric tonnes of greenhouse gas emissions annually and consumes 23 million cubic metres of water during its life cycle. Norway, which has universal baby-friendly hospital implementation, produces only 1/10 of the greenhouse gas emissions of Ireland, despite having the same number of births each year. China, with half the number of births as India, generates 10 times the greenhouse gas emissions and water consumption. By improving maternity care and reducing unnecessary exposure to infant formula in the crucial postnatal days, we could significantly lower these environmental impacts. Thank you. So we're now going to move to Constance Ching, who's a technical consultant on code advocacy and implementation at Alive and Thrive East Asia Pacific and FHI 360. Over to you, Constance.
Thank you, Julie, for the presentation. So I'm gonna start with sharing my screen, and thanks for providing this opportunity for us to, to present our digital platform that we use to monitor different settings, including the healthcare setting. So I'm going to share my screen. Okay. Okay, so So we know that in 2018, the Baby Friendly Hospital Initiative has revised the 10 steps document. The topic of each step has remained unchanged in 2018, but they have revised the wording of each step. And in the first step and the first ever sub-step of step 1 is requiring that health facilities be completely, fully compliant with the international code and relevant WHA resolutions. So I'm going to focus on this step of the BFHI. And we know that marketing of breast milk substitutes and related products is the key undermining factors for breastfeeding. Families are most vulnerable to marketing during the entire prenatal, perinatal, and postnatal period when infant feeding decisions are being made. Health facilities and health workers are being seen by companies as the perfect target and channel for promotion. And therefore, healthcare systems, including health facilities, as well as health workers and health professionals, must protect families from the commercial influence to influence their infant feeding decisions during this period. And this is some examples being shown, code violations in healthcare facilities that families are, and also new mother are and their families are getting gift packages from formula companies, including infant formula and other gifts in Singapore at a hospital in Singapore in 2017. And also on the right, there's a picture of hospital in Bangladesh when I visited in 2018 that the mothers were actually, and this is a sick child ward where they actually allow mothers to be with the child as well. But the hospitals are also being visited by formula sales reps to leave samples of formula with the mothers, which is a code violation. And this is an example that Julie provided. Thanks for that. Apart from the product, marketing level, companies are also reaching out to health workers and health professionals to try to influence their professional judgment and decisions. So here is an example where a seminar is being offered to health professionals in a hospital in Australia, in Sydney, Australia, where it's sponsored by Nestle, a formula company. And the topics are formula feeding options and issues when breast is best isn't working. So it's a clear conflict of interest, as mentioned by David earlier. We also have a study that I want to bring up, and this is a joint effort with Dr. Genevieve Becker, who's also on the call today, and with our Alive and Thrive team, that we've extracted studies that documented conflicts of interest within the health system from a global scoping review of code violations to analyze the themes of the conflicts of interest within the health system, and which is extremely worrying that these are happening through 4 decades and continue to happen right now. So David has done a very good job of covering the international code regarding healthcare systems. So I'm not going to go through each of the provision of the international code, but the overarching principle is that healthcare facilities should not be used for promotion of products that are in the scope of the code, WHA and as well as WHA resolutions. There are also resolutions that have clarified and strengthened provisions that are in the code, such as now it's clear that free and low cost supplies are completely banned to all parts of the healthcare system due to WHA resolution 47.5. The distribution of equipment and informational and educational materials mentioned in the code has also been further clarified by the 2016 WHA guidance. And David has also gone through this, so I'm not going to go through each of it, but just to mention that health workers, regardless whether the country has legal measures or not, health workers should always advocate for including the implementation of the 2016 guidance as best practice within the healthcare facility. This is also the international code provision regarding health workers. Health workers have the responsibility to support and protect breastfeeding. Just one note that I want to bring up here is that health workers are allowed to receive scientific and factual information from companies regarding the products. And this is something that companies use to try to provide promotional materials to health professionals and health workers. And I want to mention that as a best practice, health workers can always obtain preparation instructions and safety and how to use the product safely from product labels without referring to additional company materials. So we know that there are the international code, all the provisions, WHA resolutions, including the 2016 guidance, and also for some countries, relevant laws that give effect to the code. Just showing here that there are different ways of developing monitoring tools to be used within the healthcare facilities to monitor the code. And these are the earlier examples that I developed based on the IPFAN ICDC Quick and Easy form and also the Netcode Universal Monitoring form. So this is adapted from the Netcode Ongoing Monitoring form and done on free platforms such as Jotform or Google Form. And so these are the documents that you can find on the internet easily. The IPFAN Quick and Easy form from the Code Monitoring Kit, as well as the Netcode Ongoing Monitoring Kit. And these are the two documents that we use to adapt for the online monitoring form. So this brings us to Alive and Thrive, building a comprehensive code monitoring digital platform with our partners. So it first started with Vietnam with the development of Vivid, an AI detection tool. It's called Virtual Violations Detector. And then it progressed to us working with primarily UNICEF country offices, as well as with national government agencies and civil society organizations in 4 other countries to develop not just the Vivid tool, because the Vivid tool, so the 4 countries are Mexico, Argentina, Laos, and Mongolia. And later on, we're going to use Mexico as an example to show how the monitoring model that we've come up with. So the comprehensive platform has the AI virtual violations detector, but we feel that because we want the monitoring to be comprehensive, and also, for example, in this context, the AI tool cannot be used to monitor healthcare facilities, doctors' offices. So we built a model of platform that includes 3 key features. Definitely the AI virtual violations detector to auto-detect violations on digital platforms. We also have developed an online reporting form, thinking that other non-digital settings would also need to be monitored. And also we want to include the public and civil society to be included in this monitoring effort. So And this is primarily the key feature that I'll be talking about today, because it's in the context of monitoring the code in health facilities. But we also think that it's important to also include a part on the platform to provide a virtual hub for code-related learning and education materials, so that everything is in one place, including international documents as well as national documents. So advocates, policymakers, and people who are interested in the code can just go to that place to look up all the related information and materials. So this is how the online monitoring form looks like for Mexico. And this was developed together with UNICEF Mexico office, country office, as well as civil society organizations that are in the country, as well as members of the academia. So there's a committee to work with us and overlook this whole process. And sorry, this is in Spanish, but I can walk you through this. You can see that this is an online monitoring form, and healthcare facilities settings are included in the form. So for example, you can see that here we are able to pick the type of violations or the settings: promotion in healthcare facilities, donations of products in healthcare facilities, as well as gifts to healthcare workers. And so this is a closer a close-up of the different settings that we have worked into the form. So the workflow, and later on I will go back out to the browser to show you the website. The workflow is that we want the public, as well as civil society or health workers, to be able to report suspected violation through the online reporting form. And then there is a login process with the platform, where the monitor or the person or organization with the login can actually confirm the violation that's been reported. And unconfirmed violations will not be shown to the public view, because we are also careful of liability issues. We always want to have somebody confirm that something that's submitted is a violation. So once the monitor has confirmed the violation in the back end, a pin will actually appear in the map to pin the location of the violation. And this, once the violation has been confirmed, the pin will also show up in the public view. So the idea is that we want to put pressure on the enforcement agency to take action with the violation, because the public can actually see the pin location, whether it's a hospital or a doctor's office or a shop. And at the same time, an automatic email with all of the violation information that the user has, the reporter has submitted, will be sent directly to the designated government agency that's tasked with enforcement. And then the responsibility is over to them to take action on the violation that's been reported and confirmed. And once they have sent back an email to tell the person or the organization who's managing this website that an action has been taken, the pin will be removed from the map. But as you can see here, these are the entries that shows that action has been taken. So these entries will still remain on the tracker table here in public view as a record. So people can see that actions have been taken regarding these submitted violations. So I'm gonna actually go out of this view to show you very quickly the actual website, so then you can actually understand more. what this is like. And sorry, just give me 1 second. Okay, so we're here. Can everyone see the form? Yep. Okay, so this is actually the whole form that I did a screenshot. As you can see, you have to input all the information, the location, address of the violation found in this part, and also the settings and types of violation. So I have pre-entered an entry earlier. If we go to this tracker here, and then to this. Okay, so this is the entry that I've entered earlier, just as a test entry. So I've logged in as the supervisor of this website. So this is not the public view. As the supervisor of this website, you can see the email, phone number, of the reporter who reported this violation. And you also get to confirm whether something is a violation or not. So now this is shown as possible violation. And then let's say I want to, and also an email has, once I confirm this, so let's say I'm confirming this, okay, I think that it is a legit violation that's happening in a healthcare facility. Okay, once I've done that, an automatic email will be sent to the relevant government agency, and we've already set this up working with the Mexico team and they will have all the information of the violation. In here, we're only showing the city and the district of where the violation is found, but in the email, there will be the full address. And we don't want to show this too much information because of, the information is sensitive, but in the email that's sent to the enforcement agency, they will have all of the information. And then once I've confirmed this violation status, a pin will actually appear on this map here. And let me just log out. So I'm no longer the supervisor now. And if I go to this view here, you will see that once this is actually appearing in the public view. So I've logged out and this has become the public view, that no user information will be shown because it's all sent to the government agency in privacy and confidentiality. But basic information about the violation will be shown here on the tracker, which is in the public view, as well as the pin that shows up on the map. And I'm not going to log back in as the supervisor, but once I receive the information from the government agency that they have gone to look at this violation and they've taken some action about the violation, whether it's asking the violation to be removed, whether it's giving a warning to the healthcare facility, according to the national law and regulation. Once we've received this violation, I can go in as the supervisor and show and click on the status that action has been taken. So once I've indicated that action has been taken regarding this specific violation, the pin will be removed from the map to show that it's no longer an active violation, but there will be a record still recorded in the tracker here with the basic information. So this is, in a nutshell, what it looks like. This is also developed, this workflow is developed with the intention that we want the public to know about the violations. We want to put some pressure, gentle pressure on the enforcement agency to take action on violations that are reported, and also involve the public, health workers, civil society to report violations. So that is how the online reporting form looks like. And are we back to the PowerPoint now? Yes? Oops.
Yes.
Okay. All right. Okay. Sorry, I'm juggling multiple windows here. So that's one example that that I just showed, and we work very closely with the country team according to the country's need and context, and which also includes an in-country user testing workshop as well as a capacity building workshop regarding the workflow as well as action mapping. So it's a very long process, working very closely with the country, UNICEF country office, the government, the enforcement agencies of the government, or any other relevant agencies, as well as civil society in the country. We've also, so this is another adaptation of the form, and this is from Argentina. I'm not going to show the actual website because of time, but just know that with each country that we work with, we adapt to the country's needs and priorities according to the country. And as far as options, which I've shown, there are the online, basic online form options that health facilities can build can develop to use. And this is just an example that I took when I was in Mongolia in 2018 of a monitoring exercise, that there are also other ways to do this. So there's no one way to do this. And this is an example where they actually put up a hotline, a phone number, where anybody in the healthcare facility can report code violation. And this is at BFHI hospital in Mongolia. So the whole point, the key point is that we want to develop systems that allow people to report and to gather information of violation so that it generates corrective action to be taken in whatever way that we, depending on the resource, depending on the context, and that is the key message that we want to have, that we want to gather information of violations, and then we want to see some corrective action taken. And so I hope that it gives you a brief overview of how the reporting workflow looks like with the online reporting form. And I hope that, you know, something can also be developed in Australia with the healthcare facilities, and so that we will see more of what I've seen in Papua New Guinea in 2017. And I just want to highlight that Papua New Guinea is the country where they adopted they adopted a law to restrict marketing of breast milk substitutes before the adoption of the international code. This was in 1979. And in the BFHI hospital, this was a picture that this was the picture was taken from there with the mother's full consent, but I felt that we want to see more of this in hospitals. And therefore, it's extremely important that we start with step 1A of BFHI, which is to protect breastfeeding and protect mothers and parents and babies from commercial influence. When that is with, during the period where infant feeding decisions are being made, which is a very critical period of time. So thank you very much. I can answer questions in the chat box. Thank you.
So thank you so much, Constance. That certainly gives us something to chew on and to consider how we can make the most of this wonderful tool. We're now going to move to Dr. John Nak-Bitaks, who's the Director of Environment and Climate Action at FHI 360. John is going to talk about high impact actions in healthcare. Where does implementing the 10 steps to successful breastfeeding sit? What's the big picture? So thank you, John. Over to you.
Thank you so much, Julie. Andini, can I have the presentation, please?
I have
Thank you.
shared it. Can you see it now?
Yes, thank you so
Okay.
much.
Yeah.
All right. Thank you so much again, Julie, for the introduction. So hello, everyone. As Julie mentioned, my name is John from Bangkok, Thailand. I'm the Director of the Environment and Climate Action at FHI 360 Asia Pacific Regional Office. On behalf of FHI 360, thank you for your kind invitation and the opportunity to join this important conversation today. I'm especially honored to be here alongside partners and colleagues who are leading the charge to transform maternal and newborn care, not just in terms of clinical quality and nutrition, but also through the lens of climate action and sustainability. Next, please. At FHI 360, we define the concept of climate smart health care as care that minimizes environmental harm, strengthens health systems resilience, and delivers better health outcomes, especially for those most vulnerable to climate risks. Globally, as you might know, the health sector contributes to 5% of total greenhouse gas emissions. Maternal services are delivered universally, often 24/7, and rely heavily on energy, supplies, and staffing, sometimes under emergency conditions. They are also deeply intertwined with gender justice and long-term health and equity outcomes. However, in the broader climate and health conversation, maternal care often remains overlooked. This gap represents a critical missed opportunity. By integrating climate smart approaches into maternity care, we're not just reducing emissions, we are improving care for mothers and newborns, promoting health equity, and building more resilient, efficient, and reliable health systems. Next, please. Approaches to make maternity care climate friendly. There are several areas where climate smart practices can be thoughtfully integrated into maternity care. For example, improving energy efficiency and exploring solar power for maternity and neonatal units could help ensure more reliable, low emission services, especially in settings with unstable electricity. We might also consider reducing unnecessary medical interventions, such as non-indicated cesarean sections, which increase both resource use and emissions. In facilities with frequent cesarean births, shifting towards lower emission anesthetic gases could be a small but meaningful change. And in terms of waste, introducing reusable birth kits or linens and improving waste segregation could significantly reduce the environmental footprint. Reducing reliance on single-use items, for example, plastic bottles and teats in maternity wards, is another opportunity to lower waste generation and carbon emissions. Supporting a transition to breastfeeding, as we know, without early dependence on pumps or donor milk, where clinically appropriate, can also reduce environmental impacts linked to energy use, equipment, and milk transport. Research shows that breastfeeding has a substantial lower life cycle greenhouse gas, as a lot of us already mentioned, reduce greenhouse gas footprints compared to infant formula feeding, underscoring its role as a sustainable, low-carbon nutrition practice. What I just mentioned are just a few ways to align maternity care more closely with climate smart health systems goals, while continuing to prioritize safety, equity, and quality. Next, please. For the role of BFHI in climate smart maternity care, the 10 steps to successful breastfeeding as operationalized through the BFHI is a cornerstone of quality maternity care, and it's inherently climate smart. As many of you are aware, by promoting exclusive breastfeeding from birth, BFHI reduces reliance on infant formula, which involve industrial dairy production, energy-intensive processing, long-distance transportation, and packaging waste. This makes BFHI not only a public health and nutrition intervention, but also a high-impact climate mitigation strategy within the health sector. Breastfeeding is a natural, low-carbon method of infant feeding that delivers profound health, economic, and environmental benefits. Compared to formula, as we have heard already, it has a significantly lower life cycle greenhouse gas footprint, reduce water use, and eliminates the need for single-use plastics and bottle sterilization. Moreover, BFHI contributes to health equity and dignity in care, empowering mothers, reducing disparities in infant feeding support, and building more sustainable health systems. When implemented at scale and with fidelity, the 10 steps represent one of the most practical, cost-effective, and immediately actionable mitigation strategies available to the health sector, particularly within maternal and newborn care. It aligns with core principles of climate smart healthcare, which includes people-centric, low emissions, resource efficient, and resilient. In the broader context of health sector decarbonization, BFHI exemplifies how service delivery improvement can double as mitigation measures with measurable impacts and co-benefit. Next, please. In Thailand, FHI 360 has worked with UNFPA to assess health facilities using a climate smart lens. The result of these assessments help establish baseline information and prioritize both short and long-term intervention to help healthcare facilities in Thailand mitigate and adapt to climate change while increasing resilience. We have also developed a toolkit to adapt global assessment tools, such as those from WHO, to local realities. While the assessment did not focus specifically on maternity services, it highlighted infrastructure, water and waste systems, and emergency preparedness as critical factors influencing a facility's vulnerabilities to climate change. These factors are particularly relevant to maternity care, where continuous power, hygiene, and safe water access are essential for safe, respectful service delivery. Next, please. Australia's Black Summer bushfire exposed some critical gaps in emergency preparedness, including in equipping health providers to support breastfeeding and maternal care during crisis. It shows that both infrastructure and workforce capacity must be strengthened to protect vulnerable populations in emergency settings. Our assessment in Thailand revealed clear opportunities to integrate climate smart practices into maternity and primary healthcare services. This includes enhancing staff training, improving facility readiness, and ensuring consistent maternal and newborn care, even in the face of extreme climate event. Across the Asia Pacific, we've worked with partners to embed climate smart healthcare into existing health programs rather than creating siloed efforts. This integrated approach is not only sustainable, it builds local ownership and helps translate global goals into real, meaningful actions on the ground. Next, please. To conclude, I just want to mention that with the enhanced green feeding tool, we have a unique opportunity to strengthen the climate health nutrition connection even further. The start of life from pregnancy to birth and breastfeeding is a critical window to implement climate smart and equity-centered care. By greening health systems and supporting initiatives like BFHI, we can improve maternal and newborn outcomes and help build a healthier planet for generations to come. Next, please. Thank you so much for your attention. Over to you, please, Julie.
Wow, that was amazing and really lovely to see how the BFHI fits into that broader picture. Thank you, John. Okay, so now we're going to hear from Dr. Andini Pramono on the gender justice and green feeding in maternity care.
Okay. Thank you, Julie. Can you hear me? Okay.
We can hear you well.
Perfect. Yep. Okay. I'm going to share my own screen. Okay. Hi, everyone. My name is Andini, and I would like to present one of our studies related to this project. But before I begin, I would like to acknowledge the traditional owner of the land on which I present tonight, the Ngunnawal and Ngambri people, and pay my respect to their elders, past and present, and recognize any other First Nation people present tonight. So continuing from previous speakers, I'd like to start with my PhD research. As we all know, 10 Steps and BFHI have been shown to improve breastfeeding rates, and furthermore, it also provides economic benefits. So I did social return on investment studies in one hospital in Australia and one hospital in Indonesia. So we calculated the benefits of BFHI and also calculated the cost to implement the 10 steps and the BFHI. For the background context, in Indonesia, we don't have BFHI accreditation program at this moment. So we calculated the implementation of 10 steps instead. So in these studies, the Australian study showed that showed a high social return on investment. So for every $1 invested in maintaining BFHI accreditation, generated approximately $37 of benefit. While the Indonesian study showed that for every $1 invested in implementing the 10 steps, generated approximately $49 of benefits. These figures highlight the significant value of investing in BFHI and 10 steps, not just for health outcomes, but also for economic and environmental benefits. We have published this study in 2021, and you can read the full article there. I also conducted qualitative studies in the same selected hospitals. For the Australian hospital, using thematic analysis, we found that we have these two themes, time as a critical resource and continuity of care, were cross-cutting themes that frame midwives' experiences in supporting mothers to breastfeed their babies. Time constraints were experienced both through the health system structure and the BFHI accreditation process. While for the Indonesian hospital, we found that dependency on local hospital champions and a lack of budget prioritization as barriers to implementations. So I found these studies interesting to see similar problem in both countries, even they have different settings, one in high income countries and one in lower and middle income countries. The quantitative and qualitative studies highlighted the misalignment of social return, where the facilities and individual midwives and nurses bear the cost, while the benefits are received by mothers, babies, and the society. This will disincentivize the maternity services to implement the 10 steps and the BFHI. So, as we all know, the BFHI provide a framework for a more sustainable maternity and newborn care system. These steps not only aim to reduce malnutrition and chronic disease, but also improve sustainability. Key steps include adherence to the International Code of Marketing of Breast Milk Substitute and adequate training for facility staff in breastfeeding support. To lower the carbon footprint of maternity services, it is essential to reduce the purchasing, procurement, and the use of commercial milk formula. However, this transition must consider the socioeconomic impacts, including gender effects. For instance, the energy transition in the coal sector has highlighted the need to ensure women are not disproportionately affected. Similar considerations apply to reducing CMF use in maternity services. Furthermore, not all women and children have equal opportunities to breastfeed or access adequate maternity and newborn care. Major investments are required to support equitable access to these services. While there is emerging literature on gender just transitions in food systems, there is limited research on how these principles apply to reducing CMF use in healthcare. So we aim to integrate the current literature on key strategies for a gender just transition, aligning with the Sustainable Development Goals and the global nutrition targets for breastfeeding by 2030 to promote sustainable infant and young child feeding. While there is substantial research on gender and just transition in agriculture, its application to reducing commercial milk formula use remains limited. Understanding how women may be affected by shifts away from CMF is crucial. The BFHI can serve as a valuable tool for gender just transition, but it is important to carefully consider its potential impacts on women. Therefore, this review seeks to explore these issues and inform strategies for sustainable and equitable reduction in CMF use. To achieve the study aim, we conducted an interdisciplinary exploratory scoping review to characterize the literature and identify research gaps. Keywords for 3 topics there in the gold circle were developed using the Population Intervention Comparison and Outcome, or PICO framework, which organizes a search strategy around the impact of an intervention on a defined population. Using inclusion and exclusion criteria we developed for this study, we searched the 4 databases, and then we excluded papers that do not relate to IYCF or do not mention or have relation to greenhouse gas emission. We did not limit the year of publication, and all results were entered to Covidence to remove duplicates and enable title and abstract screening, and relevant studies were identified. These are the results. So after the screening, we included 1 paper for topic 1, 14 papers for topic 2, and 36 papers for topic 3. For topic 1, there's from this 1 paper that we included for the review, a significant finding reveals that 61% of ready-to-use breast milk substitute bought by the maternity service go unused and end up as waste. This highlights the potential of using backcasting methods to create effective food waste management strategies in healthcare settings. For topic 2, studies that were included in this review highlighted persistent gender issues such as viewing gender as women's issues, inconsistent gender mainstreaming, and inadequate government budgeting. Gender inequalities in agri-food systems affect women's access to resources and economic opportunities, hindering climate change adaptation. Social norms and structural inequalities limit women's access to skills, information, labor, capital, and decision-making. No study cited gendered effects on producers from reducing dairy use, and women's collective action and participation in community organizations are vital for empowerment, but significant knowledge gaps remain regarding women's vulnerability to climate change. For topic 3, we have 36 paper included in the review. Findings shows that the infant feeding practices and CMF use during hospital stays and at discharge are influenced by provider practices and maternal behaviors. Babies in BFHI accredited hospitals had higher exclusive breastfeeding rates, implying lower CMF use. Mothers receiving better breastfeeding support were more likely to avoid CMF supplementation and exclusively breastfed at discharge. CMF use was consistently lower in BFHI hospitals, highlighting underinvestment in staff education on breastfeeding. BFHI adherence significantly improved breastfeeding outcomes for infants 0 until 6 months, reducing CMF use and carbon footprints, despite challenges like CMF provision and lack of breastfeeding support. So our findings indicate a limited focus on greenhouse gas impacts of pediatric and obstetric practices or CMF use, with only one study addressing CMF waste. Gender disparities hinder effective gender mainstreaming and climate change adaptation in agriculture. Importantly, no study cited gender effects on reducing dairy use. BFHI policies enhance investment in staff education on breastfeeding, reduce CMF use during and after hospital stays, and support gender-just transition. This transition benefits mother and maternity staff without harming women in agri-food systems. Achieving global breastfeeding targets could significantly reduce greenhouse gas emissions compared to decarbonizing CMF production and implementing BFHI improves breastfeeding rates and reduces CMF use, contributing to climate change mitigations. However, barriers such as inadequate funding and support for breastfeeding still persist. A gender lens analysis is essential to ensure fairness and equity in these efforts. This scoping review is currently under review for journal publication, and it has been presented last year at the International Scientific Conference on Climate Change in Vietnam. And this review also has been accepted at Canberra Health Annual Research Meeting, which will take place this year, and also International Congress of Nutrition, which will take place this August as well. I think that concludes my presentation. Thank you, and I'll return to you, Julie.
Yes, thank you, Andini. This again is very exciting work and brings together a whole heap of issues around the BFHI and the training of staff and the budgetary cost and so on. And of course, the gender aspects, as you say. So now the green feeding tool and how to use it. I think, oh no, so sorry, we have access. Who has access to BFHI in New South Wales, Australia? So this is Professor Nasser Bagheri, who, together with Joseph, will be talking about the various aspects of the first element of our project, our MRFF project. Over to you, Nasser.
Thank you, Julie. Can you hear me okay?
Yep, we can hear you well.
Yeah.
Yep.
Hi, everyone. I'm Professor Nasser Begheri. I am a chief investigator in this MRFF grant. So I'm very excited to work with Julie and her team on this exciting project. So my talk will have two sections. In first section, I will give a brief overview of the analysis of contextual factor in breastfeeding and the health outcomes. And then we will shift to the interactive dashboard we developed through the preliminary data from New South Wales, which my colleague Joseph will explain that interactive dashboard later on. Next slide, please. So basically, at University of Canberra, we have two labs, which I'm academic director of these labs, which is a geospatial health lab and visual and decision analytic lab. These labs are complementary of each other. And then we are doing a range of activities from data management to high performance computing using the big data through the geospatial modeling, visualization, and then translation of our research to policy and practice. So basically, the philosophy of establishing this lab is enhancing communication with policymakers in public and private sectors. Next slide, please. So one aspect of this MRFF grant is looking for how contextual factor and the place the mothers live impact their breastfeeding outcome and the other health outcomes. So we are interested to look at what type of contextual factor is important in this area. One of them is social fragmentation. So I developed the social fragmentation index for whole Australia at very finer geography. In this social fragmentation captures three dimensions: attachment to the neighborhood, sharing of value and norms together within the neighborhood, and the transience from one neighborhood to another neighborhood or one neighborhood to another cities. So basically, if the attachment to the neighborhood is high and sharing the value and norms is high and transience is low, it means that there is a cohesive in these communities. So based on these three dimensions, I use the appropriate variables from publicly available data from ABS, from census data, which you know in Australia we have every 5 years the census data available. Now we have these data for the social fragmentation data for over 20 years, from 2001 to end of 2021. So the next update will be in 2026, which the next census will be finished. So basically, we use the principal component analysis to create one composite index or one composite indicator, which we called social fragmentation index. And you can see in this slide, in very finer geography level at SA1 or statistical level 1 at suburb level, in different cities in Western Adelaide in the left, in the middle in Canberra or ACT region, and in the right in Sydney or Greater Sydney. As you can see in the violin graph on in the below of the maps, you can see the average of the social fragmentation. If we compare across these three cities, is more higher in Sydney as we expected compared to Canberra in terms of fragmented population. So now we are interested to see how those mothers live in the highly socially fragmented area or neighborhood. Do they have low level of the breastfeeding rate or no? What their other health outcomes looks like. So this is one of the important indicators we are developing and linking with the Australian Infant Feeding Survey data hosted by OHW, and then looking how the relationship between this socially fragmented community and breastfeeding outcome looks like. Next slide, please. So the social fragmentation index we developed, it's published in the Journal of Psychiatry and Psychiatric Epidemiology. You can, everyone can find this article, and how that we showed that how social fragmentation relates to anxiety and depression in those communities using the real world data from GP practices, because everyone visited GPs over the year, for example, and their data is in GP practices, and we use those kind of data to estimate the depression and anxiety rate, and then relates and link with the socially fragmented communities, and to see if there is any association and link between those people living in highly socially fragmented area and their level of depression and anxiety. And we will take similar approach for this breastfeeding outcome as well. Next slide, please. So another aspect of the this MRFF grant, looking for the equity of access to baby-friendly hospital initiatives in Australia. One element here will be spatial accessibility. First, we will geocode the location of where the mothers lives to the area like SA2, statistical area level 2, which is the same size as the neighborhood, to model where the mothers live. And then we geocoded the location of all hospitals, including baby-friendly or not baby-friendly initiatives. And then we will model the travel time from the location of where the mother lives to the nearest hospital or nearest baby-friendly hospital, to estimate what's the mean or average of travel time from location of the mother's live to the nearest baby-friendly hospital. And then we are looking for where is the hotspots of the social fragmentation, those communities highly socially fragmented, and where is the hotspots of breastfeeding outcome, and to investigate how the spatial relationship looks like between the both hotspots in terms of hotspots of communities with highly fragmented and breastfeeding outcome. Next slide, please. So for this step, we are using several databases, which is the important one. We are using Australian Infant Feeding Survey, which is now hosted in AIHW. We are now in the negotiation to access the unit record of data from those data set and be able to link the socially fragmented indices to that data set. And then we will use the other data for in the different stage of process project to see how we can look at for the accessibility and the impact of the contextual factor in breastfeeding outcome. Next slide, please. Next slide. So we did a preliminary study using the data from New South Wales in Australia. So in that data, we aim to develop an interactive dashboard with the location of baby-friendly hospitals and to see how that location looks like, and linking with those infant data to look at the rate of the formula and other breastfeeding outcome. Now I'm hand over to my colleague Joseph. He can show in detail how the dashboard works.
Thank you, Nasa, for that nice background and intro. So basically, the dashboard was created using available data from the New South Wales perinatal data. And, you know, the methods basically that was used, more of a descriptive study. And basically what we tried to do was to visualize some of these hospitals as well as their BFHI status and other attributes. So in summary, from the methods, what we would say is that there are 46 studies that were included, 46 hospitals included in the study, and basic mapping was done using ArcGIS. I'll just switch to a live screen view to show us what it looks like. And if I click on screen 2, perfect. Can you see my screen? Okay, good. So basically, we're going to share the link to these maps and the dashboard later in the chat. But part of what I wanted to say, or part of what we wanted to show at the preliminary basis, is where are the hospitals located and what is their BFHI status, as well as other attribute information which we need to know about them. So first and foremost, what we did was to geocode these hospitals, as well as link the basic attribute information. By attribute, we mean some of the BFHI metrics that we want to visualize or we want to see on the map. So rather than just looking at it on a tabular view, we can basically just load the map and then see some of the basic metrics. So what I'm doing here is just, the map is panable, is zoomable. We can zoom the map and we can click on specific hospitals. Now, there's a limitation with the map view because if you're just looking at it, it's just a bunch of dots. But where this dynamic map makes more sense is that we can view different layers and as well as view a complete list of the attributes table, change base maps, and as well as other features. On its own, the dynamic map doesn't make any much difference. It's actually meant for, as in doesn't make any much impact. It's actually meant for those who are used to basic GIS analysis to create thematic maps and print them to guide the activities. I'm not going to go deep into that details. But then what I want to do is to switch over to the dynamic map and to the dynamic dashboards, which makes more sense. So what the dynamic dashboard does is that when you load it, this is definitely the introductory view. And then it comes alive with the basic data and descriptive statistics, which we want to see. By default, what we can see, or what the dashboard shows, is a basic bar chart, showing the full extent of all 46 hospitals at this moment, and some of the key descriptive statistics there. It also shows the minimum, the maximum, and also the average. Down in the middle is the list of all the hospitals. Now, simply clicking on any hospital, I'm going to put this in the middle. Simply clicking on any of the hospitals now reveals some of the statistics: rate of infant formula use, details of infant at hospitals. And if we click back again, it also shows us the full extent. So it's just interactive as it is. For each attribute that we click, the statistics also change on the bar chart and also on the speed pane. Now, what is the point of having this? It's more like giving users a preliminary insight as to what is obtainable or what is available in terms of the BFHI accredited hospitals and other details that is needed. The goal over time is to expand this to include other regions and also include more snapshots of information that users would want to see. I'll hand over to Nasser to complete that. Thank you.
Yeah, Thank you, Joseph. So basically, we will bring the other like socio-environmental determinant of the breastfeeding into this dashboard later. And when we have fully access to the national level data, so then we will have advanced spatial analysis and hotspot analysis of the social and environmental determinant of the breastfeeding. And for the first time, we are looking specifically for the relationship between social fragmentation and breastfeeding outcome, which again, we will embed this interactive dashboard later. This is just what Joseph, he's doing in the latest of his PhD, this work. And hopefully we will develop a very comprehensive dashboard, which is we can update it like say regularly if data from the adding the more administrative data to the dashboard. Next slide.
Okay, Andini, can you share this? Yeah, good, thank you.
One before. After that, please. One more. Okay, that's fine. So basically, this is just static maps here, which is already Joseph explained. So thank you very much for your attention. I hand over to Julie.
Yes, thank you, Nasser and Joseph. This is indeed a wonderful direction for our research to be going, and I'm sure people who are here tonight can see the potential for linking this data to understand where breastfeeding baby-friendly hospitals are, which women get the opportunity to access them, which women are able to live in communities which are socially cohesive and not fragmented, and how this flows through into breastfeeding and health outcomes. So watch this space in terms of that. So next, we're now moving to look at the environmental impacts of this and the use of infant formula. As we've heard, there are a whole heap of gender implications about baby friendly, and there are also environmental implications as well as health, which we're used to talking about. And so now I'm going to hand over to Dr. Duan Nguyen, who's from the Alive and Thrive East Asia Pacific, and he will take us through a quick lesson in the green feeding tool, which I at the ANU have been developing with Duan and Roger and others at Alive and Thrive over the last couple of years.
Good morning, good evening. So this is my pleasure to have the presentation on the behalf of the team. So may I have next slide, please? So so in the previous presentation, you also see that the big problem with the chromosomal formula. So in this diagram, you will see that the environment impact of that coming from the time the milk production to the time is go through whole of the process to the family for use. And the next one, please. And the tool show you very important findings. So this is very overall, but then in lower and middle income country alone, the chromosomal formula for children at the 6 months results in huge carbon and water footprint. As you could see here, 2 million cars running on the road every year with the assumption that they run 15,000 kilometers a year. And that's required more than 300 million trees to absorb. And here is also the water footprint. I try to give some of the figure that may resonate to you, including the information from Vietnam, from Sydney, from different countries in the world. And so you could have all of that information very easily by using the tool. May I have the next slide, please? And so the basis for the development of the tool, as you could see here, is based on the feeding practice and also the number of children to come up with the carbon and water footprint. And then you could see the difference between the breastfeeding and commercial milk formula to go to the estimation. So however, and we actually published several publications about that already. However, we realized that, as you could see, that's only in kind of lower middle income country where the breastfeeding practice available, we could come up with this kind of estimation. So we have an enhanced version in which you could see the one in the square. That's we also based on the number of children, but then we also base more on the sale and value of volumes of the commercial milk formula, and from that we to the middle we could estimate the per capita consumption and expenditure for commercial milk formula, and then directly from the sale volume and value, we could also come up with a different like the carbon and water footprint. So that's the enhanced version. So the next slide, please. So this is the snapshot from the green feeding tool online. So they have the different function to estimate the carbon and water footprint by country, and then you could also use your own data in case of the newer data available, subnational data from group of countries, and any type of data. And you could also have certain resources and the place that you could provide feedback. Next one, please. So for the purpose of the demonstration, then we do part. The first one is I will give some demonstration about the green feeding tool online, in which that will be some preloaded data and also some example of using our own data. I also demonstrate how the language could be changed and also to provide the feedback. In the next one would be the demonstration of the enhanced green feeding tool that's seen in the Excel format, in which you could have using the preloaded data and also a part of the using your own data. So now I would like to share my screen, please. Okay. So if you go to either greenfeedingtool.org or scan the barcode, you will come up to this online form. So they may have some bit introduction, calculate. It means that you could use preloaded data and you could also use your own data. As I mentioned, we have some resources that you could update it here, and then the feedback. So for example, if we want to have one for one country, I saw that I plan to have Indonesia, but given we have like Indonesia already, so I will go for example, for Vietnam. Just click on that, and that will automatically pop up the value here. For breastfeeding practices for the first table, and then carbon and water footprint in the next table. So you could change it anytime. Yeah. And then, for example, if you want to change to the light or the dark, you could click here. I don't know, maybe I will create, maybe because it's Vietnam, so maybe I just Vietnamese for people. So you will see that all of the value will be, I mean, the letter will change to the language. So that's really help people in assessing the information. Yeah. Okay. So also, for example, if you could see here, so for Vietnam, actually that's the data back quite old data. So now I would like to enter a newer data for Vietnam. Here you could see that's preloaded data. Actually, that's like around 10 years old data. And now when we have newer data, then that could be maybe 60% here, 30, maybe just not around in here. And then, for example, and then we also want we really want to have a higher aim. So maybe we make it like 80% here for counterfactual, and maybe 15 here, and then 5% here. And then we could also say, okay, maybe now the number of live births in Vietnam is different. So actually, I could also change it here. For example, it's now go to only like this value, and then in the position we might also maybe use the same. So we could change the number of children and also the value, and then click calculate. And for the first table, that will show you like the value that you enter, and then that will go directly to the table with all of the information. Yeah. So yeah. So that's the key thing. And actually, one of the key feature is you could come here to give the feedback, and that will pop up the a kind of the survey that you could enter and provide the feedback, and we will review and then kind of provide certain action to enhance the tool when necessary. Yeah. So now I would like to share with you another tool. That's the applied one. That's the enhanced version. So in the website that Dr. Julie Smith had shared with you, you could also have the chance to download this file. And when try to read the instruction before opening the file, because you need to have some you need to enable some factor, some component to be able to use. So for the starting, you could start clicking the country, and here you could also see that there will be two options using the survey infant feeding practice. So that's exactly the one that we have in the preloaded data in the online form. But here the new one is we could use the volume of commercial milk formula sold. So I will click on the second one. So in this, the first table, you will see that will be the volume of commercial milk formulas have been sold in two types, like standard and also special baby formula. So because in Vietnam they don't have this option, so that's become like actually zero, but that's going to value here. And you could just click on carbon and water footprint to come up with the estimate. So for here, first you pay attention to figure table number 1A and 1B. So 1B actually that's the one with preloaded data using the infant feeding practices. So you could see like the lower and upper level for carbon footprint, and then water footprint on the third column. And above is the one that we have based on the infant formula for children under 6 months, the sale of the infant formula for children under 6 months. So we could also see some like corresponding value. Yeah, I think probably doesn't be the decimal issue here. We could fix this later. And then like in table 2A is going to the lost milk, and then table 3, that's in multiple the value in kilogram of CO2 equivalent or water with a certain number, so that you could have like the value that we could kind of the costing for that. Yeah. Yeah. So now if we go to country information again, going back, and then here if you could also And the second option is you could enter your own data, enter counterfactual data, and also enter your own data for price. And then for this, we click on continue here. So that will allow you to have an option to enter certain information. For example, here again, maybe I just maybe like 4,000, for example. And here maybe they doesn't be on that year, they have a bit of this value. And for the counterfactual, for example, we just don't want to have it a lot. So maybe we have like maybe 2,000 here, or maybe only 100 here, for example. And here, as you will see, that we put the price for unit here is 75 US dollar for carbon and around 50 for US dollar. But we want to have different number. So for example, make it 100 here, maybe make it 50 here, and hit continue. So that will go to the estimation. As you could see here is the one that's our own data and the counterfactual data here. And you could also see the estimates the difference. Okay, so probably that's all for my demonstration. Yeah, over to you, Julie.
So thank you, Duan, for taking us through this. I'm rather tired of seeing this particular document, given the work we've done over the last year or so. But it's really, really wonderful to see it presented so clearly and show the great potential of the document. And in fact, what we're going to show you now is firstly some user estimates of maternity care footprints in various country settings. And the limitation of the old tool, the online tool that Duan showed you first, is that not many high-income countries have good data. But now that we have access to sales data on infant formula, we can look at the question from a different aspect and calculate directly what the carbon footprint is from infant feeding practices of children 0 to 6 months directly through it. So we're going to cross presently to a number of speakers, including Nia Umar, who will take us very quickly through the situation in Indonesia. And then at the end of these presentations, we'll surprise you with the calculations from the enhanced tool. Over to you, Nia.
Thank you, Julie. So basically, Andin, my colleague also from Indonesian Breastfeeding Mothers Association, asked me to do this. At first, I was like confused. I don't know what to do, but she guided me really well. And so this is the result from trying out the tools. So basically, as you all can see in the screen, our Indonesian annual number of birth is 4,435,250. And unfortunately, the coverage of baby-friendly hospital initiative is 10% only. It's very low, and it is the sad fact from my country. And I can say this is, but surprisingly, the breastfeeding rates keep increasing, even though the BFHI is not implemented thoroughly all over the country. But according to our Indonesian survey, the exclusive breastfeeding is now 58%. And 42% of infants from 0 to 6 months receive infant formula partially or no breastfeeding at all. So from this data, using the green feeding tool, we estimate, I think we can go to the next slide, Andin. So yes, the previous one, sorry. Okay. So after using the calculator, we conclude in the data. So what if 58.2% of infants who exclusively breastfeeding increased by 22% because of the implementation of the BFHI? And it also, here we can see the data. if we use BFHI thoroughly, so 7.9% of infant receiving infant formula will reduce also by 22% points. And the carbon footprint declines by 91.5 million kilogram of CO2, and water footprint declines by 31.133.7 million liters. So this is actually when the first Andin told me about this, I was like a bit confused, but after she guided me and I read through it and I can understand. So my reflection on this tool is, like I said, it's confusing at first, but after trying it out, I found it to be quite intuitive, and I think it has potential to benefit professionals, particularly like me, like breastfeeding consultants, public health advocates, even in environmental sectors, even the economists, for the and also for the country itself, because I think this is a good tool to understand the impact of breastfeeding. However, if we want to make the results more accessible to the general public, I think we need to show the data. We need to present it in a simple language. Maybe we can do examples with infographics, because nowadays people tend to understand more with infographics. So the findings can be related to them impact how the findings can impact them directly, so they can understand that. So that's my my experience using this tool and also my reflection. Get back to you, Julie.
Thank you. That is really, really helpful and really interesting. Now we're going to cross over to a neighboring, not so far away country, the Philippines. And I think, I'm not sure who's going to present this. I think it will be Duan.
Yes,
Duan. Present it. Yep. Over to you, Duan.
Yeah, so Dr. Paul, internet connection is not very good, so I will try to present on his behalf. So this is the one that Paul has shown some the data from the Philippines. So annual number of birth is one of the information, but actually you could see here is there's a gap between the data provided in the green feeding tool. That's around 1.8 million, and then on the other side is only the current data is only 1.45 million birth every year based on the most recent data from the Philippines. So that's the one that's the one also. And then in the previous data, they don't have preloaded data for the Philippines. However, the team could also see some of the information about feeding practice. For example, like around 40.9 exclusive breastfeeding for children under 6 months, and 11% receive breast milk plus water or non-milk water. So that's and then also the mixed feeding is around 22%. And then Dr. Paul also shared some kind of status of the feeding practice around birth. For example, like around 50% put children within 1 hour after birth, the breast after birth, and then around 50%, 75% have skin-to-skin contact with immediately after birth. And also Dr. Paul also mentioned about like only 30% of births happen in baby-friendly hospital. So here I would like to, for the next slide, I would like to share with you one with the one that Dr. Paul have addressed. So the first one is enter your own data. So that's the one that you could fix the data because before they don't have the data. And then you also fix the number of children born. And then another thing is the counterfactual, whether we want to increase like decrease 11% in partial or not breast feeding in children. So that's be the number that we enter in the lower part. And next one, please. Yeah, so this is the data that we could see like from the enhanced tool. You could see the different in terms of the lost milk and also the different in terms of the carbon and water footprints. Next one, please. Yeah. Okay, so that's all from the Philippines. Yeah, over to you, Ping.
Thank you, Duan, for presenting the Philippines situation and showing how the tool can be used. And now we have Bin, who will present on Vietnam.
Yeah. Good afternoon and evening, everyone. My name is Bing. Thank you, Julie and the team for inviting me to join this webinar and share my experience in using the green feeding tool and its potential application in Vietnam. Next slide, please. Yeah, so in Vietnam, according to the 2014 multiple indicator cluster survey we commix, there are around 1.4 million births annually, and nationally 48.9% of infants under 6 months are exclusively breastfed, while 51.1% receive infant formula either partially or exclusively. In Vietnam, the Center of Excellence for Breastfeeding, or we call COE, serve as a model of the implementation model of the baby-friendly hospital initiative. And at the latest data, 86 hospital across 16 provinces are participating in the COE initiative, accounting for around 350,000 annual births, or 22.9% of all births nationwide. Among these, more than 200,000 births occurred in the hospital that have achieved the official COE designation, representing 13.7% of national total. The exclusive breastfeeding rate during the hospital stay in COE designated hospital is 92.5%, significantly higher than their national average. Next slide, please. For the green feeding tool, I have used the tool to see how good the scaling up BFSI impact on the greenhouse gas and water in Vietnam, using both preloaded data and data set within the tool and customized local data. So overall, I found the tool well structured with clear instruction and definition that make it accessible even for the new user. So helping them understand both how to use it, to use the tool, and how the tool work. In the first scenario, I followed the instruction to apply the preloaded data, and for the counterfactual data, I use and assume 22 percentage point increase for the world out to 6 month age group, and assume that the increase in exclusive breastfeeding come from the reduction in partial breastfeeding, while the non-breastfed rate remain unchanged. And as shown in the output table on the right hand side, this change could lead to a reduction in carbon emission of approximately 23.5 to 29.9 million kilogram of carbon dioxide equivalent, roughly equal to the emission of 2.3 to 2.9 million gallons of diesel. Additionally, it could result in water saving about 10.2 billion liters, which is equivalent to around more than 15,000 swimming pools. Next slide, please. Okay, thank you. So in the second scenario, we use our own national data along with additional assumption to conduct the calculation. We applied the total number of annual births in 2019, which was 1.5 million births annually, and the inclusive breastfeeding rate in 2021, it was 45.4%. For the counterfactual, we apply the same assumption as in the first scenario with a 22 percentage point increase in exclusive breastfeeding, and draw from the partially breastfed group and with the non-breastfed rate keep unchanged. And as shown in the table on the right-hand side, this increase in exclusive breastfeeding is estimated to result in a reduction of carbon emission by approximately 24.8 to 31.6 million kilogram of carbon dioxide equivalent, which is comparable to the emission of from 2.4 to 3.1 million gallon of diesel. It could also lead to water saving of approximately 10.7 billion liters, equivalent to around more than 16,000 swimming pools. So as shared in the earlier slide, the Center of Excellence model is an implementation model of BFHI in Vietnam. This model is being actively implemented and scaled up in across numerous health facilities in Vietnam. We are interested in using this data to estimate the environmental impact of COE designated hospital in Vietnam and other hospital in other country like Laos and Cambodia. In our routinely birthing experience monitoring data, we have collected data on exclusive breastfeeding rate during the hospital stay, typically covering the first 2 to 3 days postpartum. However, the current version of the green feeding tool does not just support the calculation for such short time frame, so it's somehow limit its direct applicability to our available data. So therefore, it could be raised if the future version of the green feeding tool could support it. So that's all of my reflection. Over to you, and Julie.
Thank you. Thank you. That's very exciting and so impressive what is going on in Vietnam. I think you're setting a very high standard for the rest of the world. Now we're going to see what's happening in Ireland, where there is huge energy to improve things, and they've got a tough job, but they're getting into it. So Dr. Aoife Long will tell us what's happening in Ireland.
Lovely. Thank you so much, Julie, and lovely to be here today, everybody, and lovely to meet you all. It's been fascinating so far, so delighted to be a part of it. So my name is Aoife Long, and I'm the Senior Research Coordinator of the MaxBF project, which is funded by the Health Research Board in Ireland, and we are working towards maximising breastfeeding with people and populations. So looking mainly outside of the clinical setting to understand how our society can support breastfeeding and value breastfeeding and breast milk. So the picture to the right of the slide here, this is data from the Health Service Executive, who I suppose are responsible for promoting breastfeeding in Ireland and run a lot of the hospitals in Ireland as well. So it's interesting picking up on some of the earlier research that was presented in this, that there is a big disparity in breastfeeding rates across the country. And if you move to the next slide, the biggest challenge that we would have in using a tool like the green feeding tool is data. So for example, there's a few data points that is good data. So data is collected on breastfeeding initiation, it's collected on breastfeeding rates at discharge. So that's collected within the health service system. And then we also have public health nurse visits. So there's one visit that happens within 72 hours of discharge, and that is very high rates of, those meetings happen. It's up to 98% of that data is collected within those 3 days of discharge. So that's a very good data point. And we also have very good data point at the 3-month public health visit. Again, there's data reported, 98% compliance in reporting. But those are the only data points that we get, at point of data collection. So that's why I have a dotted line on the rates that I'm showing here. So the top one is any breastfeeding. So it's exclusive breastfeeding or partial breastfeeding. And then the middle line here is the data collected for exclusive breastfeeding. So with only 2 data points, it's even very difficult to model how breastfeeding rates decline over time. The line at the bottom of the graph, the green line, that data is extremely old. It's from a cohort data set. It's the only published data set. We can apply to later versions of that cohort survey, and we'll be doing that as part of the research project. But again, that data wasn't taken at point of data collection. I think the first cohort are interviewed when the child is 9 months. So it's retrospective data, which can be more challenging to, I suppose, understand the accuracy of it. So in terms of the country profile, the most recent figures that we have from Ireland in terms of numbers of births is 54,000 in 2023. So just some feedback on the tool, there's 59,000 preloaded. So again, having the flexibility to input your own country data would help us in using the tool. The coverage of baby-friendly hospital initiative in the country is 0% of births. So there's no, of the 19 maternity hospitals in the country, none of them have been accredited or affiliated with BFHI. So kind of in relation to the data that we have, around 30% or 32% of infants are exclusively breastfed, and that's from that 3-month public health data. So that was the data that I input into the tool when I was using it. So if you go to the final slide. Thank you. So the data that was used in the tool was that 59,000 per year. So inputting our own data, because again, our data is so poor that there's not enough data of good quality to preload into it. So I used that 32% across the board and that partial breastfeeding rate of 10%, and then applied the counterfactual of increasing exclusive breastfeeding by 22 percentage points. So again, moving from exclusive breastfeeding to increase it to higher, and brought all of that partial breastfeeding into exclusive breastfeeding. And that gets more closely aligned with the initiation breastfeeding rates, which are up around the 60%. So using the lower end of the carbon footprint data, so the carbon footprint would reduce by 8 million kilograms of CO2 equivalent per year, and the water footprint declines by around 864 million litres. So I did have, what did I say? Kind of roughly the, 4,500 barrels of oil kind of comparator for the carbon footprint. So I think the tool is very convenient to use. It's very simple to use, which is excellent. I suppose the big challenge would be us and our data. And it would also be valuable. We do have detailed data on the carbon footprint of producing commercial milk formula in Ireland, because we do have a significant commercial milk formula industry here, and that can influence advocacy efforts, and a lot of what happens in the country can be influenced by that industry. So because of that, we also do have very good data on the carbon footprint that would be valuable to input into the tool. So then we can just have more accurate data to work with. But yeah, so that's the overview of Ireland. Thank you very much.
Thank you. And hands, clap of hands to the people in Ireland that are trying to change things there. If we sort of assume that breastfeeding will just keep on kicking on if we ignore it, but it actually doesn't, as Ireland has found, and are now trying to do something about it. So now we have Melissa Bartik from the United States by video, because it's some ungodly hour of the morning there. And so Melissa Bartik will take us through the United States of America data.
Hi, I'm Melissa Bartek. I'm a medical doctor and researcher from the United States, and I'm going to be presenting the United States version of the tool. So in the United States, we have about 3.7 million births per year. We have about 24% of births are covered by the Baby-Friendly Hospital Initiative, which is higher than a lot of countries. The average number of exclusively breastfed infants in the first 6 months is about 29%. And about 70% of infants over the first 6 months get some formula. So that is national CDC data. And for the tool, the United States has to use its own data. So I took the data from the United States from the Centers for Disease Control and Prevention. We have data points at 2 days or birth, 3 and 6 months, and I averaged all those data points to get some idea of what the average breastfeeding rates would be over 6 months. And I put in the calculations that would provide the numbers needed to input for the tool. And then I inputted them into the tool. And then to get the counterfactual data, we decreased the partial breastfeeding rate by 22%, and that increased the exclusive breastfeeding rate by 22%. And once you do that, this is what you get. So by doing that 22% adjustment, we see that the carbon footprint for the United States declines by up to 360 million kilograms of greenhouse gases, and the water footprint declines by 123 million liters. Now, the tool doesn't have a way to input the percentage of baby-friendly births, and it assumes it's pretty low, probably around 10%. So we have more baby-friendly births than that, so these might be overestimates. And so that's the United States.
Well, a virtual thank you to Melissa for doing that work and presenting that so beautifully and succinctly. And we now have, I think, one more, Andini? Or no, so now we're going to go to the enhanced tool. And what's interesting about this is that the countries that struggle to get good data are the high-income countries. The countries in the lower and middle-income countries tend to have the good data, and the old tool, the online tool that you saw first from Duan is usable, but they have trouble with, the high-income countries have trouble with it. So Nabila Septiani is going to take us through the enhanced tool and show how that facilitates the high-income countries to have these calculations, because what we use is not the breastfeeding rates, is the amount of sales of infant formula in those countries, which we've got from the industry database. So over to you, Nabila.
Okay. Thank you, Julie. Hello, everyone. My name is Nabila. I'm a 2023 Future Research Talent Awardee with research on the economic and environmental impact of CMF consumption in Indonesia. Today, I will be presenting the enhanced version of the GFT, which has been designed to support evidence-based breastfeeding policy. GFT version 1 was initially developed to estimate the environmental impact of CMF, based on breastfeeding rates for infants aged 0 to 6 months. However, a key limitation of GFT version 1 was its reliance on survey data, which is often unavailable, especially in high and middle income countries. To address this gap, GFT version 2 has been enhanced through cross-validation, incorporating data from countries with both breastfeeding prevalence and CMF sales data. This new version allows us to make alternative calculations using CMF retail sales data rather than survey data on infant feeding practices. This enhancement significantly improves the tool's accuracy and relevance for policymakers. Next slide, please. We recently conducted a study in Indonesia to evaluate the economic and environmental impact of CMF using both the enhanced GFT and Euromonitor data on CMF sales. This study was also accepted by the International Breastfeeding Journal. Using the GFT, the study estimated that the environmental footprint of commercial milk formula in Indonesia included a carbon footprint ranging from 215 to 270 million kilograms of carbon dioxide equivalent and water footprint of 93 billion liters. These numbers reflected the impact of CMF cells and the displacement of breastfeeding. Comparing this result with the data from Euromonitor, we observed even higher environmental impact. Euromonitor reported a carbon footprint ranging from 300 to 380 million kilograms of carbon dioxide equivalent and a water footprint of 129 billion liters, suggesting that CMF sales are having an even higher environmental impact than initially estimated. This comparison highlights the significant gap in national statistics and the need for enhanced tools like we did in GFT version 2 to provide more accurate data for policy decision making. Next slide, please. Now, let's look at how the enhanced GFT is applied to different country groups. We use the tool to assess the impact of CMF in both lower middle income countries and high income countries. According to the 5 low middle income countries selected, the highest footprint produced is from China with 1.5 to 1.8 billion kilograms of carbon dioxide equivalent and water footprint of 621 million liters. Next slide, please. However, the tool's real strength lies in its application to high-income countries. These countries often lack preloaded breastfeeding data and also in the GFT version 1, making it difficult to assess the impact of CMF. By integrating retail sales from Euromonitor, the GFT Enhanced in version 2 allows for more accurate and relevant estimates in these countries. According to the 5 high-income countries selected, the highest carbon footprints produced is from Germany with 114 to 146 million kilograms of carbon dioxide equivalent and water footprints of 50 million liters. In conclusion, the enhanced GFT provides an improved framework for assessing the economic and environmental impacts of CMF. It offers more accurate data, particularly in high-income countries where preloaded breastfeeding data is often missing. This tool will be instrumental in shaping policies that recognize breast milk as national resource, economically valuable, and environmentally sustainable. That's all from me. Thank you for your time. I give it back to Julie. Thank you.
Thank you, Nabila. You're a star. That was great, very useful. And I think many of our testers will be very interested in those slides. So now over to the wonderful Professor Jenny Gamble, who's going to give us her independent take on tonight's proceedings. Off the top of her head, what do you reckon, Jenny?
It's a tall ask, isn't it? I guess I'm
tough. Yeah.
I'm so impressed by this work. It's amazing to be able to participate tonight. I mean, we've gone through the program. What's it called? Tooling Up the Baby-Friendly Hospital Initiative, Maternity Care for Gender Justice, Human and Planetary Health. And it's completely delivered on that. So it was so great to hear David Clark's opening remarks around the code and the enforcement of the code and the shenanigans that the companies get up to maximize profit at the expense of health. Thank you, Julie. You did a great presentation on scaling up BFHI and integrating the 10 steps into policy documents and professional standards of care, and still such a long way to go. We have a hospital accreditation system in Australia, and BFHI is not integral to that, is really a bit of a shambles. Thank you, Constance Ching. I thought that was an amazing presentation about how to monitor healthcare facilities, and you gave us options around how that could be done with different sorts of data around integration. Similarly for John, well done on the high impact mitigation actions in healthcare, and what's that look like in terms of implementing the 10 steps to successful breastfeeding. Adini, thank you so much for gender justice and green feeding and maternity care. I thought it was also fascinating to look at who gets access to BFHI in New South Wales and Australia, and how fragmentation, social fragmentation, plays such a key role. But the green feeding tool and how to use it, and all of those case studies and what that looked like in various countries, was amazing. In terms of like an overall take, being our time is short, this has got such significant gender justice implications. You know, equal power for women, equal rights for women, a holistic approach to the needs and wishes of women, and the inextricable intersect between economics at all levels, you know, household economics, countrywide economics, global economics, climate health, the use in terms of carbon and in terms of water use. They're also inextricably linked. You're just not going to get gender justice without addressing climate health and the economics. So I guess my take-home messages were, we know that the baby food industry has goals in conflict with women's and babies' needs and wishes, and that the marketing approach deceitfully misrepresents women's needs and wishes, and they incorrectly frame it as choice. And I think that happens in every country of the world, that somehow or other the narrative has developed that women are choosing this path, when in fact they are marketed this path, and simultaneously we fail to adequately support them to breastfeed. We know that baby-friendly hospital initiative implementation done properly reduces formula use, and that full implementation of baby-friendly hospital is a challenge because it's a complex change in a complex system. I think you explained that really well, Julie. Importantly, this seminar has really highlighted the tools for capturing data to accurately give us a picture of what's going on, who benefits, who misses out, rates of breastfeeding, use of formula and associated factors. And importantly, it's a tool, the tools can be used to communicate violations, access, availability, and climate health impact to all people, women, and the public officials responsible for this, to the wider public and the wider community. So I think those tools as communication, obviously to get an accurate picture, but also to be able to communicate the picture, are just so impressive. So I think some things are very, very telling, isn't it? That low and middle income countries are doing a much better job in some areas, as was highlighted, in terms of, say, data collection, in terms of buying in to the idea that promoting and supporting breastfeeding and curtailing commercial milk formula sales and activities of those companies, that is in the best interests of their country and the best interests of their people to do that. And yet in high income countries, we have to now rely on sales data for the green feeding tool. Now that's a fantastic step in the right direction, but it's also an absolute travesty. So I often bemoan that the high income countries look like they're leading, when in fact they are falling badly by the wayside in a number of key actions. So we should take very, very great care not to blindly follow capitalist countries, frankly, not just capitalist countries, but high-income countries that have put profit and company interests above the interests of the climate, but also, importantly, above the interests of women and babies. I guess I also got left with this overarching feeling as how to profile this fantastic work further. How do we take it to wider audiences and decision makers? You've done an enormous amount of work to make this picture visible, and then we need to, I think about who it is visible to. So thank you very much. It's been an amazing session. I'm so impressed with everybody's work.
Brilliant. Thank you for bringing that all together. I know it's a really tough job and you've done it brilliantly, and I'm sure our presenters will really appreciate the feedback, including me. Thank you so much, Jenny. Okay, so over now to our wonderful Roger Matheson, who has been such a delight to work with over the last few years. And over to you, Roger, to wind up the evening and point us in the direction forward.
Thank you, Julie. It's been wonderful to be working with you as well. And thank you, Jenny, for that really great summary with your reflections. I had a nice background like you others, but it somehow disappeared during the, I don't know, almost 3 hours. So we have added many tools that was shared during this Tooling Up webinar to our toolbox. And we now have a box that is full of tools for those providing a circle of love, protection, promotion, and support, including those who set policy for and offer care for pregnant women, for mothers, for infants, and their families. So if those tools are now in the right hands, we should be equipped to fix policies, to fix systems, to fix services that have failed mothers and infants, or continue to build on best practices, evidence-based guidance, and user feedback and innovations. So we may include the list of tools and where to access them in the follow-up email from this webinar. I tried to make a list, but it will take probably 10-15 minutes to go through all of them. So I'm not going to do that. But at least we will now incorporate the user and participant feedback, including from today's webinar, and finalize the formatting of the offline version of the expanded green feeding tool. The offline version will be released hopefully in a few weeks' time. And we're also seeking resources to finalize the related online version of the green feeding tool. We struggle a bit with that right now, but we hope that will also be sorted. So I just want to send a special thank you to the organizers for this webinar, including the Tax and Transfer Policy Institute at Australian National University's Crawford School of Public Policy, and the Health Research Institute at the University of Canberra. A special thanks goes, of course, to the champion in the room and the meeting chair, Dr. Julie P. Smith, for our productive research partnership, to the presenters today, the project partners and allied organizations, as you call them. Also to my colleagues, Julie, you said I should really thank them for, especially Nguyen Nguyen, Binh Ta, and Thang Nguyen, who worked over the public holidays in Vietnam. We had a Reunification Day and Labor Day holiday, but they had to help prepare for this event as well. So thank you to all the participants who joined from actually all over the world. And we will be closing this webinar by showing the new video introducing the green feeding tool. So I hope you can help with the dissemination and uptake of this tool and actually the entire BFHI toolkit. So thank you for your attention.
eligible.
Thank you, everybody. Have a great evening.
Thank you, Julie. I really appreciate it. It was fascinating.
Well done, everybody. Night-night.
Bye. Have a great night.
Bye-bye.
Bye.